بتكلم على الليفر وبكره البنكرياتيك جي اي تي. فهنبدا مع دكتور ماريز يوسف هتتكلم على راديولوجيكال اناتومي اوف ذا ليفر باي سي تي اند ام ار.
Incidence of liver disease in Egypt is very high, and we have the world rank number 1. There are about 10-45% of total deaths, and the age-adjusted death rate is 84.7 per 100,000 of population ranks. The hepatic failure and liver cirrhosis patient is miserable. He has changes in mental responsiveness and memory, spinal angiomas, collateral veins, ascites, hepatomegaly, splenomegaly, esophageal varices, jaundice, hemorrhoids, peripheral neuropathy. That's why we have a desperate need for more accurate diagnosis, better monitoring of cirrhotic patients, early detection of HCC, accurate choice of therapeutic interventional and surgical plans, better assessment of liver donors and recipients in cases of liver transplantation, and better knowledge of the liver anatomy, including its biliary, arterial, portal and venous mapping on personal base. In this lecture, we are going to discuss an anatomical background about the liver, CT and MR techniques and the radiological features, most important diffuse liver diseases as an application to the discussed radiological features. The Quinoid classification of liver anatomy divides the liver into 8 functionally independent segments. Each segment has its own vascular, inflow, outflow, and biliary drainage. In the center of each functional segment, there is a branch of the portal vein, hepatic artery, and bile duct. In the periphery, there is vascular outflow from the hepatic veins. This classification divides the liver into self-contained units. Each segment can be resected without damaging the remaining tissue. Resection lines must be parallel to the hepatic veins that define the peripheries of these segments in order to keep the liver viable. The centrally located portal veins, bile ducts, and hepatic arteries are preserved. This is the cuneiform classification. The Cantley's line runs from the middle of the gallbladder fossa anteriorly to the inferior vena cava posteriorly. It also passes through the middle hepatic vein that divide the liver into right and left lobes and right and left hemi-liver. The falciform ligament divides the left lobe into a medial segment 4, which is divided into 4A and B, and a lateral part segment 2 and 3. Right hepatic vein divides the right lobe into anterior and posterior segments. The left hepatic vein divides the left lobe into medial and lateral parts. Portal vein divides the liver into upper and lower segments. This is the identification of the hepatic segments by CT. Transverse anatomy. At the superior level, where the inferior vena cava is adherent to the liver, the hepatic veins divides the liver into segment 2, 4A, 8, and 7. While at a lower level, where the splenic vein appears, the liver is divided into segments 3, 4B, 5, and 6. The caudate lobe or segment 1 is located posteriorly. The caudate lobe is anatomically different from other lobes in that it often has direct connections to the IVC through hepatic veins that are separable from the main hepatic veins. The caudate lobe may be supplied by both right and left branches of the portal vein. The arterial supply of the liver may leave from the celiac trunk, where the common hepatic artery arises. Then it divides into gastroduodenal artery and the proper hepatic artery. The proper hepatic artery runs in the porta hepatis parallel to the portal vein and divides into left hepatic artery and right hepatic artery. The portal system appears where the splenic vein and the superior mesenteric vein run together to form the portal vein, and this appears here in a left anterior oblique maximum intensity projection MR portogram, which shows the superior mesenteric vein, splenic vein joining to form the portal vein. This is an axial maximum intensity projection contrast enhanced CT, which shows the intrahepatic portions of the portal system. The main portal vein divides into left portal vein and right portal vein, where the right portal vein divides into the right anterior portal vein branch and right posterior portal vein branch. This image shows the venous drainage, where the middle, left and right hepatic veins drain the liver, the blood to the inferior vena cava. These are common variants of the liver: the radial slope, accessory fissure, and the Chiladetti syndrome. CT and MR techniques and the radiological features. Indications of liver imaging when there is suspected focal or diffuse liver lesions, which have been equivocal imaging findings in ultrasound. Staging of a known primary. Metastatic workup of primary malignancy outside the liver. Assessment of biliary problems. Suspected post-traumatic complications. To facilitate the placement of needles for biopsy. Assessment of portal vein, hepatic artery, and hepatic veins. Assessment of liver donor. Pre- and post-operative assessment of liver transplant. Follow-up therapy of liver tumors when they are alcohol ablated or radiofrequency ablation, transarterial chemoembolization, or even resection. There are different imaging modalities which are available for the liver. The ultrasound, fast scanning spiral helical CT, which is accurately diagnose and stage the extent of disease. Sensitivity of multi-detector CT is about 86%, which drops to about 60% with lesions less than 2 centimeters in size. Angiography once widely used in diagnosis, but now is more applicable as digital subtraction angiography to interventional techniques and therapy. MR has better detection and characterization of liver lesions. It provides details of vessels, bile ducts, and ever-increasing resolution. No ionizing radiation, more sensitive especially for smaller lesions. MRA being particularly helpful for surgeons in contemplating liver resection. The computed tomography of the liver and biliary tree consists of multi-phasic contrast-enhanced CT, the fast imaging times of helical multi-slice CT enable the liver to be scanned multiple times after a single bolus injection of contrast medium. Most liver tumors receive their blood supply from the hepatic artery, unlike the hepatic parenchyma, which receives 80% of its blood supply from the portal vein. Thus, the hypervascular tumors will be strongly enhanced during the arterial phase, beginning 20 to 25 seconds after the start of a bolus injection, but they will be of similar density to enhanced liver parenchyma during the portal phase. Some tumors enhance during the early arterial phase, 25 seconds, and others during the late arterial phase, 35 seconds. The patient should be fasting for 4 to 6 hours. Renal function test should be normal. Removal of any metallic objects. No oral contrast is needed. Patient position is supine and scannogram frontal. Abdominal CT, the scanning area is from the diaphragm to the iliac crest, when the body CT, the scanning area from the diaphragm to the pubic symphysis. Contrast dose 2 ml per kilogram with maximum 150 ml and the injection rate 4 to 5 cc per second. Non-contrast scans are taken first, then the triphasic scan of the liver. The arterial is 25 seconds after injection, portal 60 to 70 seconds after injection, and the delayed phase 5 minutes after injection. Contraindications to CT, pregnancy, elevated renal functions, energy. The magnetic resonance imaging of the liver. MRI is becoming the modality of choice for detection of characterization of liver lesions. There is high specificity with optimal lesion to liver contrast, characteristics, appearance on differing sequences and after contrast agents. 3-plane true-fist localizer, 25 seconds acquisition time, followed by axial and coronal T2, short and long TE, better lesion characterization, axial T2 fat suppression, T1 3D gradient, and T1 gradient in and out phase, diffusion weighted and ADC map, post-contrast axial T1, 2D, and 3D. These are the T1 and T2. We have to discuss the basic differences between T1 and T2. T2 depends on the water content, where the CSF is bright, and T1 depends on the fat content, where the subcutaneous fat is bright and the intraperitoneal fat is bright, and the CSF around the cord is dark. This is the fluid. Axial T1 weighted, spoiled gradient, echo in phase and out phase. The normal signal of the liver on T1 is slightly hyper-intense to muscles and kidneys. The signal was variable depending on the fat and iron content of the liver. In a fatty liver, the signal of the liver in the in phase T1 is slightly hyper-intense while it drops in the out phase. Here there is a small area which is defined drop-out signal in the out phase while it's not apparent in the in phase. This is focal fatty infiltration. T2 and T2 fat set. T2, it has to be done in a respiratory triggered T2 weighted image sequence, which is preferred because it is shorter in time, and the fast recovery techniques can provide good breath hold T2 contrast with improved scan time. This is the T2 fat set, where the subcutaneous fat here is inhibited and the peritoneal fat is not apparent. Any lesion will be bright and more apparent here. We have to notice that the normal signal of the liver on T2 is hypo-intense compared to the spleen and the kidney and pancreas. Heavy T2 can be used to show water content in bile ducts, cysts, and some focal lesions. They may be obtained by, they have all the same idea of long TE. gradient echo breath hold very fast, and non-breath hold respiratory, MR cholangiography. Diffusion weighted images, it depends on the Brownian motion of H protons. The principle is to apply two identical diffusion sensitizing gradient pulses separated by 180 degrees refocusing pulse to a T2 weighted sequence. Stationary protons are unaffected by the gradient pulses because the phase shift acquired on the first pulse is reversed by the second pulse with an end result of no phase shift, which means no signal is lost. While on the contrary, moving protons acquire a phase shift from the first gradient, which is not completely reversed by the second gradient pulse, which results in a signal loss. So the stationary protons will show no signal loss, and the moving protons will show signal loss. This is an example of a diffusion images where the B value is 50 here, and here the B value is 600. The higher the B value, we have to compare the two images together. The higher the B value images will result in reduction of signal from moving protons in the bile ducts. You can see the gallbladder here is more bright than the B value 600, okay? And the water in the stomach here is less bright here. The CSF around the cord also is bright here, which is dark in the 600 P value. On the contrary, there is increased contrast between the lesion and the liver. You can see here the cord and the spleen, which are highly cellular and have less movement, less Brownian movement. They appear more bright than in the B50. The visual assessment is of value to distinguish cystic from solid lesions, but it is often difficult to distinguish benign and malignant solid lesion visually. They usually need to have the ADC number and compare the numbers, and no, there are cut-offs present for the hepatic focal lesions for the difference between the benign and malignancy. The cut-off ranges between 1.2 and 1.4. Less than 1.2 is malignant, and more than 1.4 is rather benign. Diffusion-weighted images at low B values results in black blood images of the liver that facilitates identification of small focal liver lesions, less than 10 millimeters from the dark intrahepatic vessels. The normal signal of the liver on diffusion-weighted images is the same as on the other T2. The liver is hypointense to the kidneys and pancreas and the spleen. Dynamic axial T1, which is called lava or vibe according to different machines, contrast-enhanced MRI of the liver is performed using 3D axial T1 weighted fastest point gradient echo, pre-contrast axial T1, post-contrast axial T1, either 2D or 3D, arterial phase from 20 to 35 seconds, portal phase 60 to 70 seconds, and the equilibrium phase between 3 to 10 minutes. Subtraction is needed if there is abnormal bright signals on pre-contrast T1 scans. This is a dynamic axial T1. We can see here the non-contrast where the aorta is not bright, and the arterial phase where the aorta and each branches are intensely bright. The portal phase where the splenic vein appears uniting with the superior mesenteric, and the delayed phase where the kidneys have shown the secretory phase. Contrast-enhanced MR liver imaging probably do not increase the sensitivity of focal abnormalities but may help in tissue characterization. Arterial phase is ideal for metastatic disease and HCC, the portal for hypovascular malignancies, and the equilibrium phase for cholangiocarcinoma, slow flow hemangioma, and fibrosis. Hepatic arterial phase and fast spin echo T2 sequences are the most sensitive for detection of hepatic metastasis and neuroendocrine tumors. This is the normal CT anatomy. We can revise the normal anatomic, major anatomic structures. This is the aorta, the liver, the heart, azygous veins. Those are the hepatic veins, which we can make an imaginary line from them to know the segments of the liver. This is the aorta and the esophagus in between. The stomach, the portal vein branching into the liver lobes, the spleen and the splenic vessels at its hilum, the splenic artery, the beginning of the pancreas with the splenic vein, suprarenal glands, the aorta and the splenic artery, the hepatic artery, which is usually anterior to the portal vein. Again, the splenic vein in CT and the pancreas. We will discuss a short talk about the diffuse hepatic changes according to our understanding to the normal radiological picture that we have discussed in the MRI and CT. Hepatic steatosis, this is the fatty liver, this is common and we can see it every time. The best diagnostic clue on CT, low hepatic attenuation compared with the spleen on non-contrast imaging. Non-fatty liver is normally 6 to 12 Hounsfield unit greater density than the spleen. So, if the attenuation of the liver is at least 10 Hounsfield unit less than that of the spleen, the diagnosis of fatty liver is made. And it's better to be in the non-contrast images. By MRI, decreased signal intensity of the liver on T1 out of phase gradient echo images. It can affect both lobes of the liver with diffuse fatty infiltration and enlargement of the liver. The presence of normal vessels coursing through the lesion is a very good radiological sign. This is the parenchyma, the hepatic parenchyma in a 46 years old woman with ovarian cancer who was undergoing chemotherapy. Sequential non-enhanced CT and portal venous perfusion phase contrast material with 3 months apart follow-up shows a progressive decrease in the number of the Hounsfield unit and the hepatic attenuation as shown in the circles. This is a CT scan with a post-contrast enhanced CT scan showing large 2 focal lesions, but there are vessels traversing the lesion. In axial T2 MR, the patient with focal steatosis shows no apparent mass with normal branching of the intrahepatic vessels again. This is the in phase and out phase, where the in phase the mass is not that apparent, and in the out phase it showed a drop-out signal, which is confirming the suspicion of being fatty infiltration, not a real focal lesion. Cirrhotic liver shows increased heterogeneity of the parenchymal density with irregular outline and deep fissures. In case of liver cirrhosis, there is extreme atrophy of the right lobe with normal volume of the left lobe and hypertrophy of the caudate lobe, as it has as we said, its own blood supply. Hemochromatosis. This is iron overload disorder in which there is structure and functional impairment of involved organs. Total body iron may be 50 to 60 grams. Best diagnostic clue is hyperdense liver on non-enhanced CT and marked hypointense on T2. In CT images with hyperdense liver, there are common differential diagnoses with glycogen storage disease and amiodarone therapy. Primary hemochromatosis. This is a hereditary autosomal recessive disease which defect in the intestinal mucosa increase the iron absorption, which accumulates in the liver, pancreas, and the myocardium. The spleen usually intact. While the secondary hemochromatosis, this is non-genetic caused with iron overload from multiple transfusions and bleeders, iron deposited in phagocyte cells. That's why it affects the liver and the spleen. This is axial T2 weighted image MR, which shows shrunken cirrhotic liver, but the obvious here, it is markedly hypointense with ascites varices compared to the spleen. The spleen here is normal, denoting that this is primary hemochromatosis. These are two cases of secondary hemochromatosis where the liver is in non-contrast enhanced CT, shows marked increased density in the liver. The spleen was surgically removed, and here is axial T2 gradient MR, which shows signal intensity, very low signal intensity in the liver and the spleen with that of as compared with that of the paraspinal muscles, which is confirming the secondary hemochromatosis. So the diagnostic checklists for this hemochromatosis in non-enhanced CT, if we found a dense lesion, a very dense liver, we should suspect hemosiderosis, glycogen storage disease, amiodarone gold therapy, while on MRI, if we found markedly hyperintense with signal loss in the liver and spleen, and this is diagnostic for secondary hypochromatosis. So we can summarize in liver imaging. We can see first to assess the causes of hepatomegaly with diffuse liver diseases or a localized liver masses, where Dr. Ahmed is going to cover in the next lecture. Second, it diagnoses the suspected neoplasm, either primary or metastatic. Third, it confirms or excludes hepatic inflammatory or parasitic disease. Finally, it aids planning of therapy, medical, interventional, radiological, or surgical. Thank you.